Alright, so this is GIGU. It is Thursday. It's part 2 of the second lecture of Thursday. It's such a long 3-hour day. We break it up into 2. It's winter 2021. Here we go. So, disorders of the stomach. So, very common problem. About 1/3 of all healthcare spending in the United States is secondary to something gone wrong, or complaints, GI, gastrointestinal type complaints. So it's a very common cause of morbidity. Inflammatory diseases, example Crohn's disease. Neoplastic conditions like gastric carcinoma are a big problem. So we need to, I used a word called dyspepsia before. That is what lay people call stomach upset. And you would think it just means stomach upset, but there's actually a whole bunch of symptoms that if a patient says one or two of these, it ticks the diagnosis of dyspepsia. So we need to talk about dyspepsia here. This is from Yamada, 2015. One of the best GI books out there. It is not a Board of Chiropractic Examiners book, unfortunately. Nevertheless, it's a great book. So the dyspepsia sometimes means better described as a dyspepsia symptom complex. Again, these GI problems are super common. Dyspepsia means difficult digestion, and it may or may not be associated with eating. So on any given day, about 28%, so almost a quarter of all humans, have some type of dyspeptic symptoms, and it might just happen to be on that day, once a month, or it could be every day they experience that. And only a handful of those, the minority of that 28%, will actually seek medical care for various reasons. It's expensive, and sometimes by the time you get in to see a GI doc, it's about a 5-month wait here in California. By the time you get in to see them, the symptoms may be gone. So typically someone with stomach upset has at least 2 of these dyspepsia symptom complex, 2 members of those. So interestingly, 50%, kind of fun facts here, 50% of people who suffer dyspepsia will have, their symptoms will get better with or without treatment, although it can take years for this to happen. There's 2 types of dyspepsia. There's organic dyspepsia and functional dyspepsia, and we need to get into those. So the clinical dyspepsia symptom complex, or CDSC. So there's really 8 common complaints that GI docs run into, and they've had conferences on this, and they've from all like worldwide conferences where everybody kind of says, oh yeah, well my patients always say this, and so they've narrowed it down to 8 common complaints, and these 8 complaints can be written as one diagnosis called dyspepsia, or the clinical dyspepsia symptom complex. So these are really more for functional type of dyspepsia too, by the way. You'll see what I mean by that. So a lot of stars on this slide. So who are the functional dyspepsia symptom complexes? So in order to get the diagnosis of dyspepsia, you have to have one of these, at least one of these 8, probably 2 of these. So let's go through them, and some of them we'll really dig into. So there is a botherum postprandial fullness. So right off the bat, that's kind of confusing, and I see why I don't use this. That little dot, you probably can't see it, right? That's too small to even see. So let me get rid of that and go back to my highlighter, which you can see that a lot better. Bothersome postprandial. Postprandial, post means after, prandial is eating. So it's a bothersome fullness after the meal. And if these people eat a normal, not like a huge meal or a super tiny meal, if they eat a regular meal, normal sized meal, their tummy up, they have upset in their stomach. And that's about 90% of the patients complain with this functional dyspepsia symptom complex. I'm just going to call it dyspepsia, but 90% have this problem. And so what they do is they eat very tiny meals, maybe one egg for breakfast and a quarter piece of toast, and they kind of spread those meals out, and they lose weight like this. Another one of the symptom complex is stomach bloating. Another one is epigastric pain, and that's actually quite a common one there, down by the xiphoid region. Nausea is probably not that common, but it's in here. Another one called early satiation, satiation, and this one is kind of related back to this one because they have a couple bites of food and they're full. They don't want to eat anymore. And it's probably got to do with the fact that they're eating tiny meals all the time and their stomach is shrunk, and they know if they eat much more than that, they'll have an upset stomach. So they get scared of eating normally. So that's early satiation. Belching, we know what that is burping. And then epigastric pain. Oh, no. Now, epigastric pain is different from epigastric burning. And I triple checked that to make sure. And sure enough, there is a difference between those two. A burning pain down in the xiphoid region versus a sharp pain. So those are different. And then vomiting. So the ones that are in red, those are part of the Rome 3 guidelines, a famous expert GI doc conference that was in Rome. It's the third one to talk about these types of problems. That's where they came from. All right, here's this classic study, a big study done back, it was in Sleisenger 2016. 647 patients were carefully studied, and they were carefully asked about what pains do they actually have, and this is what's listed. So there's that postprandial fullness pain. So if they just fill their stomach up, they have pain. That was the highest, followed by bloating. That's just kind of a puffy feeling, and then flat out pain, and that's epigastric pain. Nausea, early satiation, belching, epigastric burning, which is the same as pain there. And then vomiting was the most common. Okay. So there's two types again. There's organic and functional. So what does that mean? So organic means that you can find an organic, like solid problem. We can see it on endoscopic evaluation, or we can see it on histological sampling. And so there's a reason for the pain. So 30% of patients go into a GI doc, they'll find a cause, but 70% they'll find no cause. They'll go down there and look with an endoscope and take histological samplings, and there's nothing there. Doesn't mean there's not a problem, but they don't see it yet. And so that's called functional dyspepsia. Right? So that's the difference between those two. So let's talk about organic. So organic means that we can see it, and there's several different types of this. So the gastropathies or the gastritises, we're going to talk about those probably next time. About 50% of the dyspepsia pie, the diagnosis turns out the cause of their pain is dyspepsia. And we'll look at the mess of dyspepsia. There's different types of it, and it's a horrible mess with regard to classification. But the most common is an HP infection, high H. pylori infection in the stomach. We'll get into that. GERD is next. So, because GERD symptoms can mimic dyspeptic symptoms. Some people have epigastric pain with GERD, and so 20% of dyspeptic patients end up having GERD. Then we have PUD, peptic ulcer disease, about 7% of the pie. Bad one, about 1% of people actually end up having stomach cancer, or esophageal cancer can also present with any of this cluster of dyspeptic symptoms. Pancreatic disorders is another possible cause of tummy pain, from pancreatitis, from pancreatic cancer. These can all be mistaken for run-of-the-mill tummy pain. And these are bad diagnoses, right? Pancreatic cancer, that's the one that killed Steve Jobs, and I think Alex Trebek as well? That's a really bad diagnosis. A biliary tract disorder, so very common, cholithiasis, that's gallstones. And biliary colic, secondary to the cholithiasis. You get a stone down in the gallbladder neck, and the gallbladder freaks out and starts going into peristalsis really hard where it hurts. And that's a form of colic there. So those can be mistaken for colic as well. Here is the gallstone, so you can get a stone stuck right here in the neck of the gallbladder, or the common bile duct. You can get a stone stuck here, and this is all muscular tissue. It can go into peristaltic waves, will push these stones down, and if it gets stuck, you get very strong peristaltic waves. It'll cause the pain of cholecystitis, having a problem with the gallbladder, or the plumbing associated with the gallbladder. Some more causes: gastroenteritis. Maybe you've visited down south. Maybe South American, you've picked up some type of parasite. That can cause stomach upset. Tuberculosis, virus, norovirus, coronavirus, salmonella, E. coli, all of these things can cause stomach upset. Some of them resolve quickly, some of them can be there for months and months. Inflammatory disorders, celiac disease, Crohn's disease, ulcerative colitis can all cause stomach pain. And these are more rare. Mr. Spock's even surprised at some of these, but thyroid disease, autoimmune related, Addison's disease can also cause it. It's probably because of the associations. Remember, we said in patients with autoimmune Addison's disease, they often have concomitant problems with the thyroid, like Hashimoto's, but they can also have atrophic gastritis, which is an autoimmune attack of the parietal cells mostly, and we've talked about that. So they can have that as well. Hyperparathyroidism, gastroparesis, where the stomach just doesn't work right, and you put food in it and it sits there for half the day or the entire day, and the acid finally breaks through the gastromucosal barrier and irritates the stomach lining. Acute myocardial ischemia, so that can definitely cause stomach-like pain. Pregnancy, renal failure, lymphoma, amyloidosis, twisting the stomach. Sometimes the stomach can twist and get tied up on itself. That's called a gastric volvulus. Probably an intestinal volvulus could do the same thing. Mesenteric ischemia, maybe from the volvulus. Those are all causes. How about some food triggers? Well, the same triggers that trigger GERD can also trigger stomach upset. So spicy foods, you shouldn't eat these if you have stomach problems. Chocolate, pepper, tomato, red sauces. Citric fruits, alcohol, especially alcohol. That's very caustic to the stomach. Even medications. We've talked about COX-1 inhibitors like Advil and Aleve, how they can rip up the gastric mucosal barrier because they shut down PGNE2. And so, yeah, 20% of people who take them end up having stomach upset. It's better to go to a COX-2 inhibitor like Celebrex, but still, I mean, I just tore my stomach up from about 3 months on COX-2 inhibitors on Celebrex. So, they're not perfect, but they're better. I can't take COX-1 inhibitors. I can't take more than a day or two of those, and my stomach will be gone, down for a couple of weeks. Aspirin, same thing. Iron supplements, narcotics, irritate some people's stomach. Antibiotics is fairly common. Kind of ironically, for gastroenteritis, a bacterial cause, they give you antibiotics, and the antibiotics irritate your stomach just like the bug does. Digoxin for heart failure, heart arrhythmias can irritate it. Estrogen, levodopa for Parkinson's. There's many other causes. Those are the big ones there. All right, so let's go to this big category here, functional. Remember, about 70% of people, you go to the GI doc and they can't figure out what's the matter with you. And then you're diagnosed with functional dyspepsia. It's more common. I think we said 70% was the number. And there's no organic cause. They go down there and they can't find anything wrong. And there's a functional dyspepsia symptom complex that's very, I mean, it's exactly the same as these ones, the same thing. Or I mean, the dyspepsia is the same. We don't have to talk about those again. Those 8 symptoms, they can all mean dyspepsia. So those 8 symptoms that tick the diagnosis of dyspepsia work for both functional and organic dyspepsia. But there are some causes of those. So now, even though we're not 100% sure, there's some thinking that and there's some evidence that these are the cause of the functional dyspepsia. So psychological factors, we'll look at those. Delayed gastric emptying, definitely. Impaired gastric accommodation, hypersensitivity to acid or to gastric distension, so eating a full meal, stretching out the stomach. Altered duodenal sensitivity to lipids or acid, abnormal intestinal motility, central nervous system dysfunction. So let's take a look at some of these. Psychological stress is a known stomach upsetter, probably because it causes ACTH overdrives the parietal cells and you make too much acid, is the thought. Some of the stressors could be a divorce, death of a loved one, health issues, just got diagnosed with a serious disease, loss of a job, financial troubles. Those are all stressors that can probably cause the overproduction of acid. Other psychological stressors, having the somatic symptom disorder. So I learned this is somatization disorder, or somatoform disorder are definitely around. But these are people who feel real pain, but the pain can't be explained by examination, the amount of pain. Because we know people have pain, they go to the doc, and 70% of them, they can't figure out what's wrong. Some people have so much pain they're in the ER a couple times a month because of this pain, and they still can't figure out anything wrong. This might be psychologically related. It may be related to substance P and the ability to transmit pain signals. But yeah, these people very high risk for functional dyspepsia. So that's somatic symptom disorder. Other known contributors to stomach upset, especially in younger people and kids, history of abuse, emotional, physical, or sexual abuse. They could have an upset tummy with they can't figure out what's the matter. Anxiety and depression are also quite commonly associated with upset stomach or dyspepsia. Delayed gastric emptying is another known problem. In fact, I'm going for a stomach emptying test at Stanford not too long from now because I know mine is way too slow. And maybe that's why I have so much trouble with GERD, because my food and acid just sits in there forever. But this is where the stomach takes way too long to process food, and there's plenty of time for acid to be sitting in there, and it overcomes the gastric mucosal barrier, or in my case, it overwhelms the lower esophageal sphincter. And normally food is cleared in about 6 hours. I mean, for me, it could take 10 to 12 hours if I have a huge meal. If I eat a huge meal, it has to be about 2 in the afternoon now, and I go to bed about 10 o'clock. If I try to eat a huge meal at 5 o'clock and try to go to bed at 10, I'll be up sleeping in my chair, my recliner chair, in a very upright position because the food is still in my stomach. Approximately 35% of people with functional dyspepsia have lab-confirmed delayed gastric emptying. And sensitivity and specificity could be better on this, so it doesn't always relate to it. Some people have slow emptying, yet they don't have any pain, so there's probably more to the story. Impaired gastric accommodation to a meal. It's found in about 40% of patients with functional dyspepsia. And the stomach has lost the ability to properly digest food. Remember that it ain't easy if your stomach to process food. The distal part of the stomach, the pyloric region, is the crusher. That distal part, the downstream part, crushes up the food, and the body crushes the food, but the fundus, maybe the proximal part of the body, and the cardiac region, they stretch and store food, so they cannot be contracting, yet they all have the same amount of muscle, smooth muscle. So that's quite a neurological feat to make part of the stomach relax while the other part is crushing up food. And things can go wrong in that. And that's everything I just said there. So distal stomach grinds up the food. Proximal stomach has to relax, stretch, and store the food. So ain't so easy to accomplish. And this can so some of the problems that can happen with this mechanism, that was normal. What goes wrong? Well, the whole stomach grinds up food, so the fundus and the proximal the proximal body of the stomach and the cardiac portion are all grinding when they're supposed to be relaxing and accommodating the food. That makes really high pressures within the stomach. And I mean, if you have a lower esophageal sphincter that's shot, it can shoot the food right back up. And just the pressures can start to set off nociceptors, stretch receptors, which causes pain. Of course, if they went down with endoscopic evaluation, everything would be fine because that's done on an empty stomach. What about hypersensitivity or distension hypersensitivity? Some stomachs can't stand to be stretched, so these people eat tiny amounts of food to avoid the stretch. And this is thought to be one of the major causes of functional GI disorders, according to Sleisenger. And they have hypersensitivity. So what's the deal with that? How did that work? Well, they probably had an ulcer in there at one time. They probably had some pain generator. And when the ulcer healed, their brain became sensitized to that pain. Practice makes perfect, right? If you have pain for a long time, your nervous system and brain can get very good at feeling that pain. Therefore, when you remove the actual cause of the pain persists because your brain was so good at finding and feeling it. And so that's kind of the story with that. It's kind of like allodynia in a way, where they're too sensitive. Because people, I mean, you can grab people off the street, stick a balloon in their stomach and blow it up and really stretch the stomach, and they don't have any problems at all. So these people were probably hypersensitized from a real problem like peptic ulcer disease or one of the gastropathies. And then they just got good at feeling pain, and the pain continues. Back still hypersensitivity. So in the lab, below normal. So in the lab, if you stick a balloon down there, you don't have to pump it up very hard to have them get pain. Kind of as we said. The cause of this hypersensitivity, I think they are rewired for pain, just exactly like chronic back and leg pain. We can see substance P elevated in these people, and some nerve biopsy studies have shown an increased density of nociceptors and afferent fibers. So they literally become wired for pain, which can definitely happen in disc patients as well. And let's remember the pancreas. There's the pancreas and the duodenum, right? There's the stomach. There's part 1, part 2, part 3, part 4 of the duodenum. And pancreas is nestled right in there, because now we need to talk about duodenal acid sensitivity. So some patients with functional dyspepsia have been found to have hypersensitivity to the presence of stomach acid in the duodenum. But now you're saying, well, wait a minute, doesn't everybody get stomach acid in the duodenum? Yes, they do. But normally it's diluted because of the Brunner's glands secrete huge volumes of bicarbonate that takes away that hydrogen ion. It makes it more basic. Some people maybe don't. But some people seem to be very sensitive to extra acid in the stomach. So they've tested these people in the lab, and they should be able to tolerate some, but they can't tolerate any acid in there. Normal volunteers, you can stick a tube down and inject acid into their duodenum, and they don't have any problem at all. But people with functional dyspepsia, some of them just can't stand that at all. Okay, so they have. And then to make that even worse, many people with functional dyspepsia have increased levels of hydrochloric acid in the duodenum after meals. So these people, why do they get so much acid in the duodenum? Well, they have loose pyloric sphincter, especially people who have GERD, right? If your lower esophageal sphincter is loose, then your pyloric sphincter is probably loose. There's a chance that could be loose as well. Or there's something wrong with Brunner's glands, and they're not making bicarbonate to neutralize that acid coming out. What about the treatment for functional dyspepsia? Well, reassure the patient and tell them, hey, you just got tested. You should be really happy. You don't have cancer or anything like that. That's great. Reassure them. It'll pass. It just takes a long time. They might need psychotherapy, maybe some antidepressants. Remember that although psychological conditions are so related with chronic stomach pain, they may need to see a psychotherapist trained in managing chronic pain. And then eat smaller meals and more frequent meals. Don't stress out the stomach. Just let the thing heal and let the nervous system try to reset. Avoid the bad foods, which are all great, right? Spicy foods, alcohol, coffee, red sauce. Smoking seems to irritate. See if you can try to get them to quit smoking. What about medications? Well, Tums can definitely neutralize stomach, and one called sucralfate or sucralfate is a similar to Tums in a way. You swallow it and it binds to ulcers and kind of gives them extra protection against the acid of the stomach. Misoprostol, prokinetic drugs try to get the stomach emptying faster. I've just been talking with Stanford about those, and there's only one of them left in the United States now, and it has so many side effects that they just don't even want to give it to me. So there's other things that we could try to do, but it's kind of a tough problem to fix. It could loosen if some people have problems with the pyloric sphincter being too tight, and therefore food gets out in too small of quantities. So if that's the case, the pyloric sphincter can be loosened up a little bit. Medication for dyspepsia, well, treat it like GERD. Turn off the acid. So H2 antagonists and proton pump inhibitors can be used. And recent meta-analysis, placebo-controlled, the meta-analysis was filled up with placebo randomized controlled trials, and they confirmed that PPIs and H2 blockers are definitely better than placebo. I mean, we already know that. Patients might have duodenal hypersensitivity to acid, so maybe use Tums and these PPIs shut off the acid if that's true. All right. Medications, they may need antibiotics if H. pylori is a common cause of dyspepsia, so they may need H. pylori, which is treated with antibiotics. They need to kill H. pylori, which is a bacteria. We'll talk more about that, but we'll kill it with antibiotics. And yep, highly supported by Cochrane meta-analyses, because HP can really rip up and irritate the lining of the stomach. Okay, that is it for week 5. We'll see you guys next week.